Hey guys, it's Olivia. Welcome back to your endocrinology chapter. In this section, I want to talk about vitamin D deficiency, and we've covered vitamin D deficiency and the consequences like rickets and osteomalacia extensively in other videos, so I won't get too deep into the underlying mechanism here. Mainly in this video, I just want to talk about how vitamin D deficiency relates to the pathway that we have been talking about for parathyroid hormone. So first, let's talk about the different causes of vitamin D deficiency. Usually in a question stem on step 1, they're not going to just straight out tell you that someone has the vitamin D deficiency. Instead, they'll give you one of the following presentations. So poor dietary intake can certainly lead to vitamin D deficiency. Maybe think of someone who has a substance use disorder or an elderly person who is living alone, not taking care of themselves, has poor dietary intake. Decreased sun exposure, so anyone who has a skin condition that worsens in sunlight and intentionally avoids the sun could also be a clue that there's a vitamin D deficiency. Malabsorption, so things like IBD or gastric bypass. If there's been surgery on the bowel, if a large portion of the bowel has been removed, or if the bowel is inflamed, maybe you're not absorbing as much vitamin D, and that could definitely be a clue that we're talking about a deficiency here. And then anything that causes a fat-soluble vitamin deficiency. So things like celiac disease, where you might have some steatorrhea, you are not absorbing those fats as well, or the vitamins in those fats, A, D, E, or K, D being the one we're talking about here, or cystic fibrosis, which affects the pancreas, which will secrete some of the enzymes that are really important for fat absorption, along with those fat-soluble vitamins, A, D, E, and K. So those are things that can cause a vitamin D deficiency. But why is vitamin D important for this pathway? Well, quickly reviewing this pathway here, we have decreased calcium and increased phosphorus. Those are going to be the things that will lead to activation of your parathyroid glands. Your parathyroid glands will release parathyroid hormone, which goes to the kidneys and stimulates 1-alpha hydroxylase to make vitamin D into our active form. This active form of vitamin D is what is going to carry out some of the end organ effects here. So this active form of vitamin D is going to tell the gut to increase calcium and phosphorus absorption. It is going to tell the bones to increase bone turnover. Remember, first we have our osteoblasts. Our osteoblasts build bone. Those are going to be stimulated first to release rank ligand. Rank ligand is going to bind to the rank receptor on our osteoclasts, C for osteoclasts, C for crumbling bone and releasing calcium. And those are going to break down some bone and release our calcium and phosphorus. And then finally, the kidneys have one additional job, which is excreting the phosphorus and absorbing calcium. And this is the net effect of this pathway. Okay, so we can see that vitamin D is incredibly important for this pathway because active vitamin D is what is going to be mediating these end effects at the gut and in the bone. And when vitamin D is deficient, you either get one of two of the following processes. The first process, rickets, I want you to associate with children. So the pathophysiology here is that we have this vitamin D deficiency, which means we have less of this active form of vitamin D floating around. When we have less of this active form of vitamin D, then our end organs on this level here are not doing their jobs. We are not getting this increased calcium and phosphorus, which would turn off this system. So our negative feedback is inhibited. We have no negative feedback, and for that reason, our parathyroid glands are just going to keep secreting more and more parathyroid hormone. That is what leads to the elevated parathyroid hormone in vitamin D deficiency. If we have elevated parathyroid hormone in a child, this will lead to defective cartilage mineralization at the epiphyseal growth plates. And that's really key because the presentation of rickets specifically in a kid whose epiphyseal growth plates haven't fused yet is going to lead to children with bowed legs, kyphosis, and scoliosis, which are more unique to rickets than they are to other bone diseases like osteomalacia. So if you look over here, we have a patient here who has some scoliosis, that curved spine. You could also have the kyphosis, so curved forward or kind of hunched. This patient does not have bowed legs, but if they did have bowed legs, it might look something like this on x-ray or imaging. That could be a clue that you're talking about rickets. And then additionally, patients with rickets might present with fractures, poor growth, bone tenderness to palpation because we have so much remodeling going on that they're incredibly tender, muscle weakness, joint pain, or difficulty walking, certainly from all these skeletal abnormalities. Our diagnostics here should make sense if you understand this pathway. So we'll see decreased 1,25 dihydroxyvitamin D, less of the active form of vitamin D because we don't have any vitamin D to make into the active form. And then again, we'll have that increased parathyroid hormone, and that is because of this lack of inhibition, because since our end organs are not doing their job, there is no negative feedback on the parathyroids. You also might see elevated ALK-Phos here, and that is going to be due to this bone turnover and this bone remodeling that is occurring. And then you'll see normal or decreased calcium and normal or decreased phosphate. Management is going to be vitamin D replacement, usually in the form of calcitriol, so basically just give them what they lack. And that'll be the presentation of rickets in kids. But if we're talking about something like osteomalacia is very similar. It is also caused by vitamin D deficiency. You'll also see that elevated parathyroid hormone because of the lack of negative feedback. But this will lead to defective cartilage mineralization in osteoids, so not at the epiphyseal growth plate. plates. And I want you to mostly associate osteomalacia with adults. Although it can occur in children, the presentation on your boards will classically be an adult. And it'll be an adult with bone pain, joint pain, muscle weakness, difficulty walking, and fractures, all of the symptoms that you see in rickets, with the exception of the scoliosis, the kyphosis, and the bowed legs. You're not going to change the development of the bones here with osteomalacia because you are not impacting those epiphyseal growth plates, and that is why you will not see any of the bendy types of abnormalities that you'd see in rickets, so to speak. Diagnostics will be incredibly similar, so decreased 125 dihydroxyvitamin D, once again, increased parathyroid hormone, there is no negative feedback here, increased alk phos, once again, because we still have this bone turnover, that is what is creating the problem here, normal or low calcium and normal or low phosphate, and then management is exactly the same, vitamin D replacement. So that was a quick review of the endocrinology behind rickets and osteomalacia. Some of the key things that I really want you to take away are all of these different presentations that can clue you in that we are talking about a vitamin D deficiency. So anything that sounds like celiac disease, cystic fibrosis, IBD, gastric bypass, poor dietary intake, all these things that don't directly say there's a vitamin D deficiency should definitely raise your suspicion for vitamin D deficiency and can help you pick up some more points on test day. And then the things that will differentiate rickets from osteomalacia, number one, look and see if it's a kid. If it's a kid, it's a better bet that we are talking about rickets. And then additionally, look at these symptoms over here like the kyphosis, kyphoscoliosis, and the bowed legs to differentiate between rickets and osteomalacia. And the treatment for both is just vitamin D replacement. Now, how would they ask you about this on a board style question? Well, something they could ask you is a 35-year-old woman presents for evaluation of back pain after a ground level fall. X-ray reveals L3 to L4 fractures. On interview, the patient endorses 3 months of worsening diarrhea in the amount of 4 to 5 foul-smelling bowel movements per day with associated abdominal cramping, but no blood in her stools. She notes an itchy, painful rash on her back. Labs reveal normal calcium levels, but increased parathyroid hormone. What is the most appropriate treatment for this patient? So this patient with what sounds like steatorrhea, these bulky, foul-smelling bowel movements, and then that rash on her back, that sounds exactly like dermatitis herpetiformis, which is a sign of celiac disease. Celiac disease, as we know, is associated with vitamin D deficiency, and this patient is definitely having bone symptoms because she had a ground level fall resulting in a spinal fracture at 35 years old. That's not normal. So we're definitely expecting a bone pathology here, and because she's an adult, it's a lot better guess that we are talking about osteomalacia. Our normal calcium levels and our increased parathyroid hormone are certainly consistent with this, and then the question asks us, what is the most appropriate treatment for this patient? And besides treatment of her celiac disease, which will of course help with absorption of vitamin D, we should also give her vitamin D replacement. Now that's all I have for you on vitamin D deficiency. Thanks for watching this video, and I'll see you next time.